much is your treatment?
So the test is an MR test. So it's pretty much standard MR, about $3,500. And then the interventional radiology, the going in with the catheter, that's about $7,500. In general, insurance is paying for it. It's not research.
I thought insurance doesn't pay for this.
It's not experimental. The MR test that we're doing is a standard test done every day. The interventional radiologist catheter studies are done every day.
But I thought it's not a standard test for MS.
Well, the neurologists are saying this, they want this to be considered experimental. But the actual test is not experimental. The actual treatment is not experimental. They're just saying they don't believe it.
It's just a treatment for something else.
It's a treatment for venous obstruction. So what's going on in Canada is the MS patients in Canada are actually bringing together a class action suit because they're saying anyone else with venous obstructions of their neck can be treated. How come we're being singled out as we're the only ones who can't be treated?
Well, let me bring up this point.
Yeah.
Sure.
You just bring the box from the microphone. I might just put it right in the middle, right here on your legs. So I'm getting some. There we go.
Learning something for a patient really quick.
Hang on. We'll take a break for a moment.
Can you think even on two sides of our body they're all different? Arteries are all the same. Veins are much more variable when you think about the back of your hand or any vein. So we don't study them in the same way. All right, but you're dealing with an important point, which is this experimental? Is this research?
Yeah, and I mean the reason I ask this is because the guy who originated this treatment, Dr. Zamboni in Italy, as well as the National MS Society, they are urging patients not to get this treatment outside of clinical trials.
And this is a clinical trial.
This is a clinical trial.
That's what IRB means. It means that it's a trial that has been submitted to the IRB board, either of the hospital, the university, or in addition there are these national IRBs. So we actually have another IRB that we haven't talked about yet, which is a national IRB for a multi-center registry of CCSVI across the country.
Isn't a registry different than a trial?
Well, it is. So the difference between registry and trial really is that registry means you're collecting data. You're not testing a new treatment or a new device. So when we think of research, we think, or FDA research, that's really testing a new drug, testing a new device. That's when we think of a double-blind, placebo-controlled trial. Half the people get a pill that's got nothing in it, half get the real thing, a full-on trial. The hope is of the drug company is that they're going to make a ton of money on it like they are doing with the MS drugs. So this is a registry, meaning we're not testing a new pill, we're not testing a new device. It's the standard treatment these guys do all the time. What we're doing is we're collecting the data under an IRB approved protocol. So we are doing it the way the neurologists want us to do it.
But how do you know if it's effective if you don't have a placebo and the actual treatment being given?
It's much better to do it that way. Double-blind placebo-controlled is the gold standard for research.
How are you doing it?
So ours is not double-blind. Basically, patients are being referred in, they're being treated, they know they're being treated. It's not double-blind. So I'm part of this new society that Zamboni is the president of. I'm the treasurer. We're meeting in Washington, D.C. in 2 weeks to discuss this. My answer to that is to do it right, you'd have to do a sham venoplasty. You'd have to go in there, wire the thing up into the neck, pretend to put a balloon in, not do it, and that would be truly at least single blind. The patient wouldn't know whether they got the real thing or not. And then you could have an outside neurologist who was also blind to whether the venographer used a real balloon or not.
Double blind.
That would be the right way to do it. I think that's a brutal study, and we're not even close to ready. So I see it as a little bit ingenuous of the neurologist to say, don't do anything until that kind of study can be put together. Who's going to pay for that study? If NIH is going to pay for it, they're not going to do that for 10 years. There's going to have to be all sorts. Somebody's going to have to collect some data before anyone's going to do a big study like that.
So you're saying it's almost inhumane to pretend to perform surgery on somebody just so they think they had surgery?
I do. The term that's used in this field is compassion. Is it compassionate? So there is a guy, a good guy, Zavadinov at University of Buffalo, that is doing that in 10 subjects. He's going to give 10 of them the sham and 10 not.
But aren't you jeopardizing your work's credibility by not doing a study like that?
Well, I think, let's be even more bald about it. Aren't I a quack who is taking advantage of a desperate population that may think they're better because they want to feel better, right? So in general, people do feel better right after the procedure done in Delmar. And so that part of that's got to be placebo. You know, they're so excited, they've finally gotten the treatment. That is going to happen. In general, that can be expected to do for a few days, but not 2 years later. Some of these people are 2 years out and they're still very much improved. So I don't think it's enough to say it's placebo. I understand that neurologists are saying unless you do a double-blind placebo control, you can't rule out placebo. But no one talks about placebos 6 months, 2 years out. Placebo is typically something in the hours to days range. So my answer is yes, a double-blind placebo-controlled trial is necessary. But just collecting any data is also necessary. If we weren't doing what we're doing, not here only in San Diego, but across the country, so we have a multi-center trial, so that doctors around the country can participate in this. Otherwise, these people will be lost to follow-up. Right now, they're going to Europe, Bulgaria, Egypt, Kuwait. That data is not being collected by anyone. At least we are collecting the data. We're using a validated MS instrument called the MS Impact Scale. We are collecting the fMRI data. We're having everyone come back at 6 and 12 months. So I think we're doing the right thing. I think if we just waited for a double-blind control study, it would never happen. It would never happen.
So go ahead with the treatment because the study's not going to happen.
Because that study, the double-blind placebo control in decent population, that would be a multi-million-dollar trial that Big Pharma is certainly not going to pay for, and NIH is not going to pay for as long as the neurologists are so against it.
Let me ask you this question. Is it responsible medicine to administer something that has not been studied and not been vetted to the full effect?
Yeah, that's certainly something I have to face. Of course, that's what we do every day, right, is we try a medication that has not been proven for that use. Most treatments...
Who does that?
Everyone does. So antidepressants. Antidepressants are FDA approved for depression. But we physicians, all physicians, use antidepressants for all sorts of things. Aches and pains, insomnia, lots of things. So those are off-label uses.
But I would say our antidepressants are not an invasive surgery.
Antidepressants probably kill more people than catheter venography. Catheter venography, as far as we know, there's been one adverse event. Michael Dake, one of the top vascular surgeons on the planet at Stanford, he put a stent in. In general, we're ballooning the vein. Put a stent in, the stent fell out of the jugular, went into the heart. Never happens. Terrible timing for the guy. They shut him down. The chairman of neurology at San Francisco was furious, called up the chairman at Stanford, made him stop. He's out of business for now. He's waiting to try to get an IRB again. And obviously I'm in a little bit of a strange situation because my son gets diagnosed. I review the literature. I'm convinced that what the neurologists were going to offer him, these immunosuppressing drugs, are more dangerous, more deaths occur, and they don't work. So I made the call that my son would have this catheter venography. It's not in the artery. It's in the vein. So there's almost no risk to it at all. You have a risk of a little bleeding in the groin where you put the catheter in. If you put a stent in, there's the possibility the stent can move, but that's incredibly rare. It's not surgery. It's really more like putting an IV in.